I can start talking. My name is Jane McPherson. I'm a HAS member on the Science, Medicine, and Technology Committee. And we'd like to welcome Luke VanderZouwen. Did it Zoen? Say it for me. Okay. All right. Sorry. I'm not Dutch. I'm not from here. So I have to get used to how you say these names. So Luke is a Hope College graduate in physical exercise science. Yes. Thank you. I should just read it, I guess. I thought I had memorized, but I've forgotten. And he did get his doctorate in physical therapy from Central Michigan University. And he has a lot of expertise in physical therapy for a wide range of musculoskeletal disorders, which lots of us have. And he did some extra training in the management of TMJ syndrome, temporal mandibular joint syndrome, which as we age, some of us suffer from more, and some of us even suffer from more young if we're teeth grinders. So he has some expertise in that, and also has a special interest in working with people with chronic pain and helping them cope with their pain and improve function so they can more readily enjoy the activities that they like and improve their quality of life with that. So a lot of modalities for physical therapy that Luke has focused on over the years that he's been in practice. He's currently a full-time physical therapist in a private practice here in town. And so he's got a lot of experience. When he's not working, he, like almost every physical therapist I've ever met, is sort of a outdoors and exercise nut. Sorry, as a bookworm, I was never really much of an exercise nut, but I've gotten better as I've gotten older. So I think I read that you dabble in Olympic weightlifting.
I do like Olympic weightlifting.
Wow.
Yes.
And not just as a spectator, you do it.
A casual practicer, not a competition level.
Okay.
That's by any means.
Okay. Well, that's pretty impressive. And he does rowing, cross training, running, likes almost every outdoor activity too, camping, backpacking, and even some bird watching if you have a lot of leisure time. But you have a couple kids, so probably not a lot of time to, unless they want to watch birds.
Trying to get them interested too.
Yeah. Yeah.
Working on it.
Yeah. They tend to scare the birds away. Anyway, so I will turn the presentation over to Luke, but I do want to ask everybody to silence your cell phones in some fashion, turn them off, airplane mode, whatever it takes. And I always think I do, and then still somehow something rings or dings. So we won't hold it against you if it makes some unplanned noise. And then I think we're going to try to do questions at the end. He saved time for questions at the end. So, okay, we'll let you take the floor.
All right. Well, thank you for the introduction, Jane, and thanks for coordinating things. Amy helped with things too, and thank you all for attending. So my name is Luke VanderZouwen, big, long Dutch name, so I usually fit in pretty well in Holland. I grew up over on the other side of the state, but like Jane said, I went to Hope for my undergrad and decided that I really like this West Michigan area and have been here for the last 7 years working at a clinic here in town called Full Potential Physical Therapy. I see a few familiar faces out here. So yeah, I've seen some of you around, but I decided that I wanted to talk about basically the benefits of physical therapy for a lot of different type of situations. And I wanted to make that as evidence-based as possible to give you guys the best up-to-date information on what's going on. And what I found was I actually learned a lot during the preparation of this presentation too. It's a changing field like anything with medicine. There's always new things coming out, new evidence, new things being confirmed, and new things being maybe seen as old news, so to speak. So we'll get right into it. Jane already covered most of my background. Like she said, I do have an interest in orthopedics. So there are all different types of physical therapy, which we'll get into, or different niches when it comes to physical therapy, but orthopedics is what most people have heard of. It's your classic kind of musculoskeletal focus, so bones, muscles, joints, how the nerves interact with that. And that is what I tend to focus in, and with the clinic that I'm at, it's mostly what we see. I have a special interest in pain science, which in general, the reason that people come to see me and come to our clinic, there are some exceptions, but for the most part, pain is one of the things that they're coming for. It may be related to other issues, but all of them, most of those people have that in common, most of the clients that I work with. So it's a very valuable tool for me to be interested in that. And we'll get into that a little bit later too. So some of the objectives I have for today are to, one, just provide a brief history on physical therapy. Not everyone's had physical therapy. This is one of the areas that I got to learn about. I know a lot of the nuts and bolts with physical therapy, but I got to do some digging into, how did the profession start? So we're going to outline some of that. We're going to outline some of the effects of aging on the human body. We are all aging. We're all at different levels or different ages. So we have different things that our bodies are experiencing, and I want to go over some of that. Offer some evidence-based examples on how movement can promote health, especially in light of some of those age changes that tend to happen. Then I want to review some of the basics of a well-balanced movement program or practice, I like to call it. So not only just tell you what's going on and what physical therapy has to offer, but then also how can you take some things from this presentation and maybe even coordinate the way that you are going about a movement practice. Then lay out some resources with establishing a movement practice of your own. So in general, the target audience, I guess, that I have, being you guys, is for the most part, people without a ton of health needs. So there are going to be exceptions to all of the things that I'm talking about and trying to kind of encapsulate as much of the population as possible. It's not necessarily meant to be a one size fits all. That's where physical therapy can come in handy later on, as it can be tailored to you specifically. So like most disclaimers before a medical talk, it's make sure if you're going to take these into practice, speak with a professional first if you have any doubts. So getting into the history of physical therapy, I guess before I get into that even, show of hands so I can know my audience a little bit better. How many people here have had physical therapy at some point? All right. So people are somewhat familiar with the concept of physical therapy. All right. But not everyone. So we'll still go over some of the basics. But back to the beginnings of physical therapy, really started post-World War I. There were a lot of military veterans, sometimes even during the war. So active people in active duty coming or needing help with war-related injuries. That, along with the start or the ramp up of the polio epidemic, really had it made for a need in the medical field of some type of professional or some type of trained medical advice for people to have that was not maybe just the one-time visit with a physician, but something that would see them for a longer period of time and watch change and make sure that change was being fostered in their lives. So that was kind of the start. At that point, it was called a reconstruction aid, oftentimes under the umbrella of a certain physician, and they would have these reconstruction aids that they would tell them what they need to do with this individual, and that individual would be ideally brought back to health and either get back to serving or get back to their quality of life following World War I, or as related to the polio epidemic. We go forward a couple of decades, the 1920s and 30s, it started to be physical therapy, that is, started to be recognized as an actual profession, kind of a subset of the medical field. So this is where we first start seeing the word physical therapy or physical therapist, or in other countries oftentimes called a physiotherapist. So you'll still hear that sometimes if physical therapists are practicing over in Europe, they're often called physiotherapists. During these couple of decades, the polio epidemic continued to rage. World War I started up during that time. So it was still needed for a lot of the same reasons, just for different world events. In the 1940s, there was a lot of change in the medical profession. A lot more hospitals, major hospitals, especially in urban areas, started to open up. And we started to see even more and more physical therapists needed, not only for war-related issues. Granted, this was as World War I or World War II was wrapping up, but also just for the general population also. 1950s, 60s, and 70s, we're getting into more modern times now, and there were still wars going on that, again, physical therapists were needed, not only near the front lines, but also at home as veterans returned. Fortunately, by this point, 1955, polio vaccine, which some of you may have received. Polio vaccine was created, so the need for specific physical therapists that did all their work with these polio patients really started to go away, and that's a very good thing. But physical therapists stuck even beyond that. So now we get more into what is considered the modern age of physical therapy. So 1970s and beyond, it's when it's been an established practice in and of itself. Physical therapy is defined as an intervention aimed at restoring or improving function as related to movement. So this could be either limited movement, impaired movement, painful movement, but in the medical world, we're kind of known as the movement specialist. If it's movement related, chances are there's a physical therapist somewhere involved in that treatment. Physical therapist, then, we just defined physical therapy would be a movement expert that is trained in physical therapy. So that's me. I have a 4-year undergraduate education at Hope, as we already mentioned, and then I have a 3-year doctoral degree. So I went to Central Michigan. That's pretty much that is now the standard for physical therapy, is if there's a new physical therapist or one that has graduated from physical therapy school in the last 10 years, they'll be doctorally trained. So one of the reasons for more schooling beyond a master's, or even before that, it was an undergraduate degree, is that it is just a complex field with a lot of moving parts, like any medical practice or medical professional. They all have complexities to it. And more physical therapists are being expected to have some autonomy in their practice. So less and less under the guise of a physician, and more we're being seen as some of the gatekeepers to the medical field. So if you come to me or you come to another doctorally trained physical therapist, it's expected that we are not physicians. However, we have some at least idea of differential diagnosis to be able to determine if you are really needing physical therapy or if you need some other care. So trying to get you to the right place. And I think that's been one of the main reasons that it's changed to a doctoral degree. There's also more research involved now than there was 10, 15 years ago, as physical therapists are trying to determine their own path a bit more. There are all different types of practice settings. Like I said, I practice more in you call it an orthopedic style clinic, but there are hospital-based physical therapists. There are home healthcare-based physical therapists that come to the home for individuals of high need. There are inpatient physical therapists. There are skilled nursing, working in nursing home physical therapists. There are just a lot of different settings. There used to be more in industry, like big companies would have physical therapists on staff. For whatever reason, that's gone out of vogue a little bit. But what I'm getting at is there are a lot of different types of physical therapy. What I'll speak on mostly today is the orthopedic side. There are different specialties within physical therapy also. I don't have a specific board certified specialty. Even though my interest is in orthopedics, you typically have to be in the field in that area for about 10 years before you can sit for one of these exams to get extra letters after your name that says you have extra training in a certain area. But I wanted to cover that just because it hits on some of the different needs in the populations we work with that physical therapists are trained to be around and to help with improving the quality of their life. So there could be cardiovascular, pulmonary physical therapists that specialists there, specialties in geriatrics, neurology, oncology, orthopedics, pediatrics, sports, something that I don't even know what it is, so I need to do a little bit more, but clinical electrophysiology. I did not know that was a specific board certified specialty, but I guess I have a little bit of research to do on my own. There are specialties in women's and men's health, and then also one in wound management, which I think is a bit of carryover from some of those early days of physical therapy, when there were a lot of overlaps between nursing, physical therapists, and medics, even close to the front lines. So now we've talked about a little bit of an overview of physical therapy. I like to get into kind of the meat of what I wanted to talk through today, which is more some of the effects of aging on the human body, and then how does physical therapy play a role in that? So this subset of slides here, the next 4 or 5 slides, is based off of a review that was done through the Mayo Clinic, a pretty respected clinic, that talks about different body systems and some of the effects that aging alone even in absence of a lot of comorbidities, aging alone will have on the human body. And it's going to be maybe a little bit of a downer for the next couple slides, but then I promise it'll get, I'll try to raise things back up a little bit. So we're going to go system by system. And one thing I want you to pay attention to is next to the system, just how many of those systems physical activity can have a positive effect on some of those aging aspects. So cardiovascular system, something that we see pretty commonly, and it's a theme in some of the other systems too, is a stiffening of some sort. So stiffening of the blood vessels within our body tends to have an increased workload for the heart. So the heart has to work harder. We see things like more rates of hypertension, so high blood pressure, and some other cardiovascular issues that arise because of that. So pretty common to be seen there. Things without managing through pharmacology that can be effective in reducing some of those, we'd call those side effects of aging: physical activity, diet, things like smoking cessation, stress and sleep management. So physical activity, I made bold there. The digestive system, similar, we see somewhat of a stiffening of those tissues over time. Age-related structural changes, especially seen in the large intestine, can lead to things like constipation. Again, physical therapy or physical activity can be effective in mitigating some of the effects of those structural changes. Bladder urinary system, again, stiffness or reduced elasticity in the bladder urinary tract. We see things like increased frequency, so having to go more often, maybe difficulty with full emptying, which again results in having to go more often. Higher risk of things like prostate related issues, which can also result in some difficulty emptying and incontinence. Memory and thinking, so this would be seen as our nervous system, involving mainly the brain, but also other nervous system structures within our body. Some structural changes within the brain do occur. There are some oftentimes reduction in available neurochemicals that are important for processing, memory, these type of things. Reaction times we see slow a little bit, can result in difficulty with memory and some thinking skills. And again, this is an otherwise relatively healthy individuals. Physical activity has been shown to be a way that, again, some of these changes can be at least slowed or function can be maintained. Having regular mental challenges. So that's one of the reasons I think this group is awesome, and that you guys have, I was just learning today from Jane, 8 or more lecturers in a week potentially that you have access to that can teach all kinds of new things and make you guys think in all kinds of new ways, which I think is awesome for anyone. Visual system, auditory system, some structural changes that go on there again in the eyes and ears, oftentimes relate in some loss of hearing, especially higher frequency hearing, and then also some visual difficulties over time. Teeth is considered a system in and of itself, according to Mayo Clinic. Some gum recession, things like dry mouth, more often will have some issues with tooth decay and infection as those tissues age. Our integumentary system, which is our skin, again, we see some reduced elasticity or some stiffening there. Less stretch in those structures results in things like wrinkling. There's less fat tissue or adipose tissue right underneath the skin level. So what happens oftentimes is there's a higher incidence of things like skin tears or of easier bruising in those areas too, along with potentially some other medications that are fairly common can cause some of those things also. Wearing protective clothing, sunscreen, really important. Again, over and over we see smoking cessation through this too. Pretty well established now, smoking is generally not good for people. Weight, which they considered a system. I think what they're trying to get at with that is the metabolic systems that we have within our body, especially hormone production and whatnot. We see things like a general slowing of the body's metabolism. So becomes a little bit harder to manage weight at times if caloric intake stays the same, which means a greater potential for weight gain. Physical activity is a really good way to help manage that also. Then things like, of course, diet and portion control. Sexual systems or reproductive systems see things like certain dryness in tissues, so less slippery tissues, sometimes for males, difficulty getting erection, issues with sexual function, and enjoyment can sometimes follow with that, not always, but sometimes. Physical activity has been shown to be effective in helping to manage those also. So I'm getting to some patterns here you're seeing. Then kind of getting into more what we're going to focus on the most through this and getting into the evidence-based side of it later on. We've got the bones, joints, and muscles. And that's what a lot of people know physical therapy from is bone, joint, muscle related issues. So in bones, one of the things that's oftentimes seen is reduced bone mineral density, especially in females, but even in males. There are certain hormones that can promote bony growth, or if those are absent, we see some things like bone resorption and issues with calcium uptake and things like that that promote strong, healthy bones. So that can occur. Osteoarthritis is another thing we see that would be in with bones and joints. It's the interface between bones and joints is where you see things like osteoarthritis. Some of these changes can result in things like a higher incidence of fracture and some postural changes that take place over time. Physical activity is probably behind diet. It's like 1A and 1B as far as the things that are important when it comes to managing bone health. Our joints, again, we see things like osteoarthritis occurring. So this is, we'll get into it more in a little bit, but some thinning of joint space because of thinning of cartilage, some bony wrinkling or bony changes that happen, roughening of bone. These are all things that can happen at the joint. They oftentimes result in some stiffness and loss of mobility that can be associated with pain during movement later on also. In our muscles, in general, there's typically a reduction in muscle mass, strength, endurance, and flexibility or stretchiness of those muscles. A lot of things that were once stretchy and mobile start to stiffen a little bit as we age. General physical capacity can be limited in these cases, and sometimes it can even impact coordination and balance. Again, for all of these, physical activity is a really important feature in promoting health in these tissues. The other thing is we now get into a little bit when it comes to comorbidities. Like I said, I'm not going to hit a ton on that today. That's more on an individual basis. But there was a really interesting study done a few years back. They went as far in the title, which is lack of exercise is a major cause of chronic diseases. They went as far as to say lack of physical activity can be a cause, or lack of exercise can be a cause, which is pretty strong terminology when very rarely is that being said in the research world. I would say it's more of a strong correlation, but they went as far as to call it a cause. But lack of exercise in one's life puts people at higher risk of a lot of different things. And you can read the whole laundry list here, be it sarcopenia, which is loss of muscle mass, hypertension, stroke, congestive heart failure, some cognitive dysfunction and mental health issues like depression and anxiety, different types of cancer, colon cancer, breast cancer, GI-related issues, diverticulitis, gallbladder diseases. There's a whole laundry list of things that are involved when there is a lack of exercise that at least there's a higher risk of. Not necessarily a cause, but a much higher risk. So hopefully by now you're seeing movement, physical activity can be an important thing. And again, I told you it would be a little bit of a downer, those last few slides. There's not a ton of positive information on that when it comes to the aging process. However, there is some hope for managing through that aging process and putting yourself in the best spot going forward. So what happens when you don't know how to move, or for some reason you can't move well? And this is where physical therapy can sometimes come in. So we're going to get into that a little bit. So when it comes to moving and not moving well, in my practice, I see a lot of different barriers to that. So just got a picture here with some hurdles. There's some hurdles towards being able to move well. And I think that for just about everyone, as we go through the aging process, just as we live our lives, at times we come up with different hurdles. Some of the ones I see most as reasons for people not moving well would be things like quote unquote degenerative joint changes. And we'll get to later why I put quotes around that degenerative term. But osteoarthritis, degenerative joint changes, some bone quality changes. We touched on that a little bit with bone health, muscle loss or strength deficits, balance concerns. Sometimes it's need for surgery, either eventual need for surgery or not moving well as the result of what led up to a surgery and then what happened during a surgery. So we'll get into that some too. And then the number one reason, like I said, one of my interest areas is pain. A lot of people are coming to physical therapy due to pain, and they're not moving well because it hurts when they move. So first off, I want to get into each one of those, but first off is arthritis or osteoarthritis in particular. There are different types of arthritis. Osteoarthritis is what most people are talking about when they say, I have arthritis. We're not going to get into some of the more pathological arthritises like rheumatoid arthritis, for example, is one of those. But osteoarthritis is typically seen as changes around a joint. And those changes around a joint are characterized by thinning of cartilage. So all of our joints, the ones that move at least, have a layer of cartilage that sits in between the bones. And that cartilage over time tends to thin. And if there are cases where that can be affecting function and whatnot, or it gets to a certain level, they'll call that an osteoarthritic change. There can also be some bony deformation that happens surrounding a joint, whether that is some spurring. You'll hear words like spurring, or you'll hear words like stenosis or spondylosis. Those are all ways of describing some of the bony changes. Typically, there's some roughening of the bone, and those are all ways of characterizing some of the changes that happen. We see things as far as symptoms related to osteoarthritis. The number one symptom is intermittent stiffness. So oftentimes that's in the morning that people will say, I'm stiff, or after periods of inactivity, they'll say, I'm just extra stiff. Well, if a joint doesn't have quite the lubrication it used to because of less cartilage, quite the padding, it's going to be more prone to stiffness. That can sometimes result in limited movement if there's some bony changes that have happened that are actually blocking some movement or keeping that movement from happening for whatever reason. Maybe it's a spur that's bumping into something that doesn't want to be bumped into. That can sometimes result in more long-term limited movement. Sometimes there can be swelling at joints as the body's trying to go about a healing process, but it's struggling to do so. Oftentimes there's a feeling of instability. This is sometimes related to that idea of, or what I hear often is a joint just wants to give out, or clicking and popping and feeling like it's moving awkwardly, which gets a little bit into joint noise. There can be some joint noise, some creaking, or I like to call it Rice Krispies in the joints. When you turn your head and you hear Rice Krispies popping, that's oftentimes related to maybe a little bit of bony roughening or some thinning of cartilage, not necessarily a disease. So oftentimes this is called degenerative joint disease. I think that's a little bit of a misnomer. Now, there may be some extreme cases or some other features that promote some of these changes where maybe it could be called a disease. But what I like to think of this as is it's wrinkling on the inside, and it happens to almost everyone. I would say, I mean, we'll get to a slide here that shows a little bit of how many people deal with some of these degenerative changes, but it's called a degenerative joint disease. We don't call wrinkles degenerative skin disease, but we all tend to wrinkle as we age because tissues change a little bit. Same thing happens within our joints, and I have a little bit more optimistic opinion about it. I know that's easy for me to say, being that I'm 33 years old and have only just started that process of developing some of those changes, but we'll get into why I'm a little bit more optimistic than some in the medical field, or optimistic about some of the things that could be done to help manage some of these changes. Probably covers this slide. So the pattern you'll see with a lot of these slides is that I go into what are some of the features of these different barriers, and then what is some of the evidence telling us. And I tried to get the most up-to-date information that I could find. Some of that was from my schooling 7-8 years ago. It's still up to date because not much has been published beyond that. And others, these were new studies for me to find that were good for me in my learning and my continued learning. I tried to get as many, they're called systematic reviews, as possible. And for any of you that have been in research in the past or have read research, you know that systematic reviews are one of the highest levels of evidence because they take a lot of individual studies, they compile them into one, and then they try to find conclusions based on that. So this first study, physical therapy interventions for patients with osteoarthritis of the knee. The knee is a highly studied area because a lot of people deal with knee issues. It's pretty easy to image, and it's pretty easy to do follow-up study on. So this first study is actually an overview of systematic reviews. So it's taking systematic reviews, which are already an overview of a bunch of studies, and then overviewing them. So it's high level, high quality research. And what it shows is in 23 systematic reviews, it was something like several hundred studies that were compiled together. There's high quality evidence that exercise and weight reduction reduce pain and improve function in patients with osteoarthritis of the knee. So this idea that I have some bone on bone, you'll hear that, and it is going to be a downward spiral from here on out, and I should stop moving, is the last thing that I want people to believe. Now, are there certain cases, we'll get into this too, where surgery is needed? Absolutely, there are cases. However, as a first line, I think exercise should be a part of that first line, because what we're seeing more and more is exercise, and especially weight-bearing exercise, is really good even in osteoarthritic joints. Now, that needs to be modified in some people, and it needs to be a graded exposure to exercise, especially when there's pain involved. However, it can be really good for actually promoting health, even in absence of a reduction in that osteoarthritic change. Rarely do I see, in fact, never do I see someone have a film that says you have this level of arthritis, and then a year later have a film that says, oh, your arthritis is gone. That doesn't happen, but it's a management process. I wish that happened. That would be really nice. Then I might not have a job though, so maybe that wouldn't be so nice. Further, getting into some of the nuts and bolts of how does that exercise, what should that exercise look like, I guess. Exercise for osteoarthritis of the knee. This is another systematic review. And what it showed is that over a period of time, these people were given land-based, so just non-water-based essentially, land-based exercise. So what I take that as weight-bearing exercise up and on their feet. And what they showed is that not only did they get some short-term benefits, reduction in pain, improved quality of life, but actually when they took part in that sustained exercise over the course of, I think this was 6 weeks, under the guidance of a therapist, what they showed is that even 2 to 6 months later, they were still having some of the results as far as pain reduction and improved function that they got from that 6-week course of care. There's other studies, again, related to the knee, in this case, the hip also, which are two highly studied areas, being that they're two of the joints that are most affected by osteoarthritis, showed that supervised care. So what I take this as is guided care of some sort, oftentimes by a physical therapist, can help with giving people individualized treatment for what their given need is. I think there's a lot of value in things like YouTube and things like personal trainers and whatnot, but when we get into some of the more complex situations and it's very individualized, I may be biased because I am a physical therapist, but I think physical therapy is a great avenue for providing some of that consistent and guided care to promote better function. This gets into more of the spine. So we talked a little bit about the knee. We got into the hip a little bit, but to the spine also. I found this to be an interesting graph. On the x-axis, we have age. So this is someone's life over time, essentially. And then on the y-axis, it's tracking two different markers, that one of those markers being age changes in the spine or wrinkles on the inside, and then how often people were seeking out care for lower back pain. And what they found, interestingly, well, maybe not interestingly based on what I'm saying, and maybe what some of you have experienced, over the course of our life, we tend to age in our spine, meaning we have more changes within our spine. So the green markers there are showing that over time, marked from 20 to 70 years old, sure enough, there's a trend that people get more arthritic over time. But that's not the trend for where people are seeking out care for lower back pain. We tend to see that more in what would be considered middle-aged individuals, so 30 to 55, 30 to 60. And then there's actually a drop-off in the incidence of people seeking out care for lower back pain. And there are some extraneous variables in there, no doubt, but a lot of people assume that both of those graphs have the same trajectory, and it's just not always the case. So moving on a little bit from osteoarthritis, we get into things like osteoporosis or osteopenia, another barrier that people have when it comes to moving well. So osteoporosis, it's a skeletal disorder in which bones weaken. There's some risk of fracture that is increased with that also. We see a reduction in bone mineral density, and when it gets to a certain level, it's called osteopenia. When it gets to a level beyond that, it's called osteoporosis. Some of the microarchitecture, so the structure that makes up the bone, in certain areas, it settles into more. Those areas that are most commonly seen as having osteoporotic changes would be the hips. You hear about a lot of people fracturing hips related to some of those bone quality changes. They're at a higher incidence of fracture. And then spine is another area, and you hear about things like when it is progressed and maybe there's injury associated with it, things like compression fractures. It's most prevalent in postmenopausal women, oftentimes because of the role in estrogen and promoting bone mineral density. And when that estrogen is lowered, it's part of the process of laying down good bone. Our bones are constantly changing over in everyone. And that process is changed a little bit when there's that lack of estrogen. So you hear about it most in postmenopausal women, but it is not just in postmenopausal women. Interestingly, I think at least interestingly, exercise is one of those things that I think is oftentimes overlooked when it comes to osteoporosis. Think about things like diet or supplementation, or maybe it is going more the pharmacological route in certain medications. I think those are all very important avenues. But one of the things that a lot of people have control of that they don't even know is trying to incorporate exercise into their life. What we're seeing, and it's been corroborated by experts in the field in this first study here called Too Fit to Fracture, is that moderate to vigorous exercise is one of the best things for promoting bony health. Unlike arthritic changes, which I said, if I do a film for someone, or I have their physician order a film, and it's going to show they have a certain level of arthritic change, 2 years later, they're probably going to have the same, if not a little bit more. Doesn't mean function and pain, but they're probably going to have the same or a little bit more. With some of these osteoporotic changes or osteopenic changes, bone mineral density changes, what we're seeing is that if given moderate to vigorous exercise, oftentimes that's resistance training exercise. So think strength training, which can have different looks to it, but strength training. What we've seen is that actually there can be improvement in some of these. Oftentimes it's along with other interventions as well, whether that be pharmacological or diet as well. But we see actual positive changes in that. So the term that's oftentimes used, or the test, is called a T-score, and we see improvements in T-score numbers, meaning that you can have improvement in some of those bone mineral density numbers. Again here, we see that a lot of the study has been done on postmenopausal women because that's where a lot of these changes are more profound. And a really interesting study, the second one listed on this screen, long-term exercise and bone mineral density changes in postmenopausal women. Are there periods of reduced effectiveness? So essentially what they were trying to determine is, will this get less beneficial? Will it not have as much of an impact over time? There's pretty good evidence that short-term we see changes. This was actually looking at long-term what happens. And it's pretty rare in studies to have a 16-year follow-up. This was a really long, continuous study. But what they showed is that in exercise groups versus non-exercise groups, and the exercise groups were given some guided treatments to go about, or in this case, some guided exercises to go about several times a week. And then they were asked to continue that on their own. So they were independent in that beyond, I think it was about a year that they were independent in that and doing it on their own. And what they show is that there isn't like a cap that at a certain point, these exercises are less beneficial. What they actually saw is the difference growing and growing the more it was done. So essentially, the more you add in and the more longevity you have in this resistance training program, actually we see more and more and more changes between exercise groups and non-exercise groups, for the positive being the exercise group. Now moving more into the muscle side of things, here's Arnold Schwarzenegger. He's not struggling from muscle loss in this picture. Maybe that was chemically enhanced. Well, I'm not sure, but we see things like the term sarcopenia. If you've ever heard that term, less often have people heard that than they've heard osteoarthritis or osteoporosis. But sarcopenia is defined as a progressive and generalized loss of skeletal muscle mass and strength. So with that generalized loss of muscle mass and strength, some things tend to occur with that. There are implications for bone mineral density changes. So if those muscles are not able to pull on bone as hard because they're not as strong or there's not as much mass there, what tends to happen is that bone isn't stimulated as often, and therefore we see things like some bony mineral density changes. Muscle is metabolically active tissue, meaning just when you are sitting here, your muscles are burning calories, where your fat is storing calories at that time. So we see things like higher potential for weight gain, some metabolic disorders that are involved with that progressive or generalized loss of muscle mass. This has implications when it comes to falls also. Strength is a big part of our ability to maintain our equilibrium. And if that starts to be lacking, higher risk of falls. Functional dependence, so needing other people to do things for you, just being generally less active because that strength conditioning is not there. There are many factors that can be at play in that loss of muscle mass. There are some endocrine function implications, especially with hormones. We think like in men, there's a lower level of testosterone, which is an anabolic steroid, meaning, or an anabolic hormone, meaning that it promotes a gain in muscle. See a lowering of that over time. And there are some also some nutritional features of that too. But for instance, if someone is malnourished in a certain vitamin or mineral, there's potential for some loss of muscle mass. And then we see physical activity as being a major contributor to that as well. So in general, not with everyone, but in general, if we're looking at a group of 5,000 people, most of them will report that as they age, they become somewhat less active, whether that's because they're not chasing the kids around, or maybe they are set up in some social organizations that maybe don't promote that. Who knows? But the general trend is people tend to be less active than they were 10 years ago. So by promoting activity, the nice thing that we can see is that even aged muscle, it's very plastic, meaning it has the potential for change when given the right stimulus. It responds to anabolic stimuli, which is another way of saying in fancy physical therapy terms, it responds to resistance training. And when resistance training occurs, what we see is that there can be some reverse or at least slowing of that muscle mass loss. And that can result in improved function. And I think is a hopeful thing to think about. In general, I'd say almost everyone knows I should be doing things like aerobic activity. Some people also know I should be doing some balance work. Strength training, especially I find for women, it's changing maybe a little bit as culture shifts and whatnot. But what I find is that there's kind of a lack of either education or a lack of education training for women to be engaging in strength training activities. And there may be some cultural implications there that need to be overcame. But what we see is even in women, even in frail elderly people, strength training can not only be safe, but it can also help with some of these muscle loss changes. So first study here shows that the effects of resistance training with moderate versus heavy loads on muscle mass and strength in the elderly. So it's trying to show, are there effects even in elderly individuals? And this is people above the age of 68. And what they find is that exercise training, especially in this case, resistance training at relatively high loads, is not only safe, so this is 80% of 1 rep max. That's a pretty high load when it comes to strength training and conditioning world. But what they found is that at high loads, people tend to have positive effects, the most positive effects, even though at lower loads, so less weight with certain activities on a given muscle group, there's still a positive effect. So the best comes with high load, but the next best comes with even low load. So essentially it's saying some resistance training is a really good thing, whether it's high load or low load. the next study, what I wanted to show is that it doesn't have to be people who are already strong that are engaging in strength training. Because a lot of that I find to be the case. People say, I'm strong, so that's what I want to get into. I have a desire to be stronger because I'm already strong and I take pride in that. But even people who would be classified as being frail. So what classified people as being frail is they have a history of falls within the last year and are trending towards physical dependence. So needing some extra help within the home. I think they included people in nursing homes, but what they showed is that even in these individuals, strength training is safe and it's beneficial. So this was 16 studies that were included in this individual systematic review, and that they showed it's quite a range, but 1 to 6 sessions a week, 1 to 3 sets of 6 to 15 repetitions at a whole variance of loads, from relatively low load at 30% to relatively high load. So this would just be how much weight they're using. They showed that across the board, whether it was the 1 time a week with relatively low load or the 6 time a week, they found that each and every one of these groups had an improvement in maximal strength, an improvement in muscle mass, again, quite a range there in those, and reported at least some improvement in functional capacity. This also equated to reduced risk of falls. So again, rarely in the research world do we see such profound findings from a systematic review. Over and over again in research, you see with systematic reviews, there's some evidence, but not enough to be significant. Some evidence, but not enough to be significant. This showed even in the least beneficial group, it was still highly beneficial. In the most beneficial group, it was very, very beneficial. So again, not only seen to be beneficial, but also safe, because that's a concern. Anytime you're working with someone frail, you don't want to cause more injury than you're trying to help. Another area that I see a lot of people for, this is probably outside of painful situations. The number one reason I'll see people is balance concerns. So that can be a huge barrier towards moving well, either actively having falls or the fear of having falls. All these can be part of a major barrier towards movement. So balance is defined as the ability to maintain equilibrium, where equilibrium can be defined as any condition in which all acting forces are canceled by each other, resulting in a stable balanced system. That's a long mouthful. Essentially, it means the force is acting on you, you're overcoming. Gravity being one of those forces that's acting on us. So when balance is not maintained, and it's not maintained and not regained, this is when it results in a fall. So there are different features to balance. One is there has to be some level of prerequisite strength and mobility. This is where muscle mass and strength can sometimes play into balance. If I'm not strong enough to maintain my body against gravity, I'm going to be up a creek without a paddle, so to speak, when it comes to balance. Certain mobility. If I have certain joints that are really stiff or maybe can't move as fluidly, tends to happen as I'm at a little bit higher balance risk. Then there are 3 major systems, all that interact with our brain, that are important when it comes to balance. So this is our visual system. We rely a lot on our visual system for reference point when it comes to balance. So that's why if it's a dark room or if I close my eyes and move my head, especially if I move my head, I'm having some trouble with balance there. The somatosensory system, this is our body awareness system. So as I start to lean forward, let's say, I have a whole subset of reactions that happen that turn on certain muscles that my body senses I'm being stretched. I'm feeling pressure in these areas. And amazingly, my brain can coordinate that and my spine can coordinate that information, and it can help me with regaining my balance. If there are any things going on with that, we see things like peripheral neuropathies, sometimes some other pathological issues even beyond that. But the somatosensory systems can be affected in a lot of different people. Makes balance a little bit harder. Then vestibular system. If you've ever heard of vertigo, most people that are experiencing vertigo, if you've ever had it, you know, balance is really hard in that case. That involves the inner ear, and there are all kinds of reactions happening, whether you have vertigo or whether you don't, that are going on between your inner ear and the fluid moving around in the inner ear and all the sensors there, that is compiled and brought to your brain. And amazingly, your brain can take that in, and it then gives an output and tells you where you're at in space and keeps you balanced. any of these systems, if not working quite up to par with how they should be, can affect your balance. So impaired balance, it's a big issue in our world. A study in 2018 showed that 27.5% of adults 65 years of age and older have had at least one fall in the last year. That is a huge number of people when you think of all those people in the age, especially the age of baby boomers now, where that population is growing and growing and growing. 10% of individuals over the age of 65 had a fall-related injury, which equates to 8.4 million fall-related injuries of all different levels, from minor scuffs that required a hospital stay or a hospital visit because of maybe a cut or a bad bruise, to fractures, to even death in extreme situations. Those are scary numbers, and falls are scary. What I tend to find in a lot of the populations I work with who are dealing with balance-related issues is they also have a propensity for being less active. And it makes good sense. If I'm fearful of a fall, or I've had a fall, I'm not going to take many chances when it comes to maybe having another fall. And the best place to not take a chance is sitting down. And oftentimes sitting down in a recliner chair, because that's what's comfy. And then over time, what happens is more and more people are seeking out some of these sedentary behaviors, and that can sneak up on you over the course of years and result in some of the other findings that I talked about when it comes to osteoarthritis, osteopenia, more balance issues, loss of muscle mass, more functional dependence. The good news is that there is some hope in this situation, and that's that practice of balance situations over and over again with high quality evidence we see promotes positive change in balance. So again, unlike the arthritis example I went over, we actually see really positive effects on objective measures and in follow-ups after people have gone through either exercise training or specifically exercise training in concert with some specific balance challenge. Another systematic review here showed some of that interaction I just talked about, that I think fear, this is actually saying the opposite. Sedentary behavior promotes falls. But what I see is, I think it's a chicken or the egg situation. I think sedentary behavior promotes falls, but also falls promote sedentary behavior. And it starts this cycle that can be really tough to break. Getting into that hopeful side that I just mentioned, though, what we see is that physical activity programs for balance and fall prevention in the elderly are very effective. So in this systematic review of 8 different articles, they showed, again, across the board improvement in each and every one of those studies when there was some general exercise in the form of aerobic and resistance training, some formal balance training, and then some complementary features here that are not necessarily across the board, but just basically implements used for that balance training. What they showed is that 16 to 42% of individual, there was a balance improvement of 16 to 42%, which the numbers, I don't really care about the numbers. What I care about is, does that promote reduce falls and promote improve function, those numbers? And what they found is that, again, across the board, it does. This also doesn't have to be something based on this other study where there's this little data table here. It doesn't have to be something that's done, 3 hours a day, that's highly intensive or anything like that. What they show is that over a period of about 11 to 12 weeks, which is the average that I'll see someone for high-level balance training when they've had a history of falls, they show that if you're training under guidance a couple of times a week and then maybe one other time a week on your own for a session of about 20 to 30 minutes, maybe a little bit longer at the beginning, these people have high levels of evidence saying that they've improved their balance after about 6 weeks, and then can maintain that with less input, after 11 to 12 weeks, and then can maintain that with even less input. So gaining balance is a lot harder and takes a little bit more intensive training than maintaining balance. And I find that to be hopeful in that if you can go through this period of maybe a little bit more time, which again, in the grand scheme of things, half an hour a day, 3 days a week, I mean, that's a lot of time, but it's not 6 hours a day or anything like that. There can be really positive changes that happen with that. that then can be carried forward into an exercise routine on one's own. Now getting into a little bit more the need for surgery. There are a lot of things that require surgery. We get into, especially in the slides that I'll go over, the knee, hip, and spine. And a lot of that is in relation to osteoarthritic change to some extent. We're going to talk first a little bit about surgical prehab, which I think is something that is oftentimes beneficial, but oftentimes it is also kind of put to the side. I'm going to need surgery on this. Why would I go through a rehab process? I've already maybe been deemed a surgical candidate, or my mom and my sister have both had knee replacement. I'm going to need knee replacement. I may as well just live with it until I get to a certain age where the orthopedic surgeon will say, now I'll do a surgery on you. What we're finding is that even in some pretty severe cases of osteoarthritic change, again, this is back to the other study that was in one of the first slides, exercise and weight loss reduction or weight reduction can improve function and can reduce pain in individuals with pretty severe knee osteoarthritis changes. I think in this case, as we'll get to some of the other body areas too, a lot of times we have kind of a no loss situation. And that's how I sell it to people who are coming in quite skeptical to physical therapy. We have a no loss situation. We know that you may need a surgery. However, after that surgery, you're going to need to be strong at that joint. You're going to need to be able to move relatively well. We're going to need to reduce stiffness. We're going to need to get you in good working order whole body wise through engaging in some physical activity so that you recover even quicker. That's the one win. Surgery is still needed. Well, we're no worse for the wear than when we started, except that now we have all these other positive features going on. Then the other major win, and this is always a fun thing too, if someone says, I know I'm going to need surgery, they go through physical therapy or they go through this training and a movement practice, and they realize, I think I'm actually doing okay. I can probably postpone my surgery. And that happens from time to time too, and is always a really big win. But what I'm getting at is there can be, in this case, I think a no loss situation. If someone gets no better, the good news is usually a good physical therapist won't see them for very long, and they'll say, you're doing the right thing. You can be confident that you're going into that surgery. So even that could be considered a third potential win. It's just peace of mind knowing I've tried everything conservative ahead of time. At the hip, we see similar information. And again, oftentimes these surgeries are related to osteoarthritic changes. What we see is that exercise therapy, in addition to patient education, can reduce the need for total hip replacement by 44% in individuals with osteoarthritis. So this was where they had levels of change that were deemed appropriate for eventual total hip replacement, but they actually could either postpone or just not get their hip replacement, which is pretty amazing when you think about the main feature being exercise and a prehab program that is the key feature in reducing that need. For the spine, this was in people who actually underwent spinal procedure. What we see is that in this randomized clinical trial, they showed that when individuals who were deemed appropriate and scheduled out for a spinal procedure, most of these were spinal fusion procedures, some laminectomy procedures. What they showed is that 2 months of rehab before that given procedure, they found that they had faster recovery to milestones. So that would be things like being able to leave the hospital, being able to walk independently, going about all their quality of life measures. They found that they had faster recovery to those milestones, improved operative satisfaction, so they were more happy with the results that they got. And then I think one of the key things that people are coming into physical therapy in those prehab situations with is a lot of fear that physical therapy might hurt them. And what they found is that there were no more complications either before the operation, during the operation, or after the operation in the groups who had that pre-surgical rehab and the groups that didn't. So again, I see this as a little bit of a no-loss situation. All these structures have been obviously having issues and probably are weakening to some extent. there's been pain in these situations because they're scheduled for these surgeries. So that's likely what's been happening. Either you're the same point that you were going into that surgery and you didn't gain much from physical therapy, but you had no more complications, or you actually gained strength, you gained some function, you had some reduction in pain. And these are the cases I run into quite often, and some of the research now that I point people to. Surgery is, though, needed. And a lot of what I do, not the majority, most people think it's the majority, but a lot of what I do is post-operative rehab. So this would be your classic after knee replacement type of therapy, or after a spinal procedure type of therapy. I'm not even going to talk about the knee very much. That's pretty much widely known in the area and across the country and in the world. It's pretty standard. You have a knee replacement or you have a knee procedure, almost 100% of the time, physical therapy is at least advised in those situations, because it's just shown over and over and over again. I couldn't actually find any current data because all the data was old and was so good that I think no one is studying it anymore. Physical therapy after a knee surgery is shown to improve outcomes, reduce pain, and improve function. The hip, even in the area, less people automatically will go to physical therapy. I'd say the minority of people actually go to physical therapy following, at least immediately following, a hip replacement. And I've always kind of wondered about this. And this, again, was really good information for me to see some of the reasoning behind that. And I think it's pretty valid reasoning. So at the hip, this first study, which was a randomized controlled trial, high-level evidence shows that formal physical therapy after total hip replacement is not required. Pretty cut and dry. They don't beat around the bush there. What they found is that there were minimal differences in self-reported outcomes, what they're basing that title off of, minimal differences in self-reported outcomes at 10 weeks post-surgical. So this study was done just 10 weeks post-surgical. In my knowledge of physiology and healing, there's still a lot of healing that is happening beyond 10 weeks. So first off, I'm a little bit skeptical. I mean, it makes sense that then immediately post-op, they may not be coming to physical therapy. But what we're also seeing is that at 1 year, so further out from surgery, there are pretty significant differences, or there are significant, I don't even have to say pretty significant differences, there are significant differences in postural stability on the involved and the uninvolved side. So what it's saying essentially is one side, the side that was operated on, is oftentimes weaker, and it has poorer balance on that side. That alone, I think, makes it beneficial to potentially seek out some physical therapy, at least in the relatively short-term time after a procedure. The other thing I come to is with this research, it definitely serves its role. I try to do as much evidence-based as I can, but research is for big groups of people. What I'm oftentimes worried about is that one person who falls through the cracks. So what I see, and again, I'm biased in that I'm only seeing these people, I don't see all the people that are doing really well, is the individuals who come to physical therapy 6 months after a procedure, especially a hip replacement, and they're just not thriving. And they say, all of my friends who have had this are doing really well. Why am I not doing well? And I say, I'm really sorry, but from what we see, every once in a while, someone falls through the cracks a little bit and their body does not thrive. And then I always wonder back to, I don't have any empirical data right now to go off of, but I always wonder, if I had had some time with this person, even a few visits in the first couple of months, to go through some things to catch some of the issues that they're having, would I have been able to catch them before they started to fall between the cracks? So again, I don't have any empirical data, so I won't profess that that is the absolute truth, but it's always in the back of my mind, and I wonder a little bit. With spinal issues, again, what we see, pretty similar. When people start physical therapy 2 to 3 months post-op, because spinal issues are also another one of those. The evidence the advice I hear a lot is walk. Everybody should just be walking. Walk as much as you can, walk as much as you can. Again, some people fall through the cracks, or some people are having a difficult time walking. And what they find is that starting physical therapy 2 to 3 months post-operatively for a guided exercise routine improves not only short-term results when it comes to pain and function, but also long-term function at follow-ups. A little bit less conclusive at those long-term follow-ups, but it still is some lower level evidence that even long-term people are more well off. Now getting into pain. Everybody sees that and thinks it hurts. Some of you have maybe done that before, stepped on a tack. But pain is the number one reason that people seek out physical therapy. So I like to spend some time talking about that. And it encompasses all of some of these other issues. Most of the time, people aren't coming to me because their T-score went from this to this, or they're not coming to me because their film showed that they had arthritis. They're coming to me because they're saying, I'm in pain and I think it's related to this, or I'm in pain because of this, or I had a fall and now have pain in this area, or I strained this area trying to do something heavy. That's what they're coming to me for. It is a highly complex system that when we're talking about pain, and I like to get into a little bit of talk there, and then we'll get into some of the what do we do about some of these other issues, or how can you start up a movement practice. But this picture here, I just like to briefly go over because I think it shows a lot when it comes to how pain works in our body. We have this complex set of nerves that surround our whole body. There have been some studies that have shown we have about 45 miles of nerves, from the big nerves like our sciatic nerve to all the small, even unnamed nerves. If we put them all in a row, there's about 45 miles of those nerves. Those nerves are all kind of humming along at a certain level of activity, basically just saying you're alive. They're humming along at that level. When something happens, maybe it's stepping on that tack, those nerves, they spike in their level of activity and they send a message up to the brain. And that's what that rise in the graph is there. If those nerves are firing to a certain threshold, what happens is our body will experience pain. And it's this complex interaction between our brain, which is made up of a lot of different nerves, and our body. We'll experience pain. Ding, 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 alarm goes off. That is actually a really good thing. That's telling you, hey, get that tack out of your foot so you don't get an infection, or so that you don't keep pressing it further and it starts hitting on other structures. In most situations, short-term injuries, short-term painful situations, with time, and we get the tack out of our foot because the alarm was going off, with time, that tends to go back down and it hums along at its normal level. And that's where, again, it says normal level of electrical activity. That leaves a lot of room for activities to happen before that threshold is reached again and we experience a painful issue. In some situations, though, we're finding in about 1 out of 4 people that have some of these short-term painful situations, turns into a longer-term issue. So even beyond 6 months of pain in some of these areas. What we see is that nervous system, it does calm down some after reaching that threshold, but it doesn't calm down all the way, and it stays at an elevated level of sensitivity. And what this does is it just means those nerves are that much more sensitive, whether it's nerves within the brain or nerves within the body, and it takes less and less to fire that alarm. So that alarm system starts going off more and more and more and more, and it leaves very little room for activities. Good news is there are ways to calm down that nervous system, and there are ways to calm down that alarm system. We'll get into that a little bit. I think generally movement is a major one that I like to use. But that can stay elevated also for a number of different reasons, not just that the tack wasn't removed. Once the tack is removed, your body goes through a healing process and things come along. But in some people, and this is just using that tack analogy again, they'll stay painful at that for a long time. And there can be a lot of different factors that can cause one's cup to overflow. When one's cup is overflowing, they're experiencing pain. That may be the physical stress itself. Maybe the tack tore through some tissue, caused some damage. Well, that damage takes a certain time to heal, and that may be causing that cup to overflow. There can be maybe some other structural things going on, joint changes, any of the first things that we talked about as far as barriers. There can be things like emotional or mental health things, depression, anxiety, fear over the situation, coping strategies that just aren't there. There can be some misdiagnoses. There can be comorbidities that can all be part of that. There can be stress in one's life that keeps that system somewhat elevated so that that alarm is going off more and more frequently. So it's the short-term pains. Those are the easy ones to deal with. It's the long-term pains where the water starts to get more and more muddy that tend to be most difficult, and actually what I like to work on most, because Those are the most fun when you can take someone who's had pain for a long time and try to make them function in at a higher capacity and have less pain. That's very gratifying, and one of the reasons I like doing what I do. So trying to get that cup not to overflow. That's ideally something that is not just managed through physical therapy, not just managed through movement, not just managed on your own if you're having difficulty, but it's multidisciplinary. So ideally, a lot of different disciplines, if needed, are involved in giving a similar message. Physical therapy in and of itself offers a lot of different tools for either taking out some of those stressors, not all of them, but some of them, so that the cup doesn't overflow anymore, or for using the alarm system analogy, calming down that alarm system. So these are all the tools of the trade. So manual therapy, massage, mobility training, strength training, conditioning, ways of coping with difficult situations and moving better. So activity pacing, working through gradual exposure to previously painful things, some modalities, ice heat, ultrasound, and then also sometimes being a gatekeeper towards other professionals that can help with different situations that are filling that cup up. So now you've been sitting for the last, I'm even going a little longer than I thought, the last hour or so. And I profess movement, and then I have you sit for a while. But there are some general features that I like to stick to when it comes to either keeping up with a movement program, but especially with introducing a healthy movement program for the vast majority of people. And the first thing is consistency. Anything done for a short amount of time can be beneficial for a short amount of time. Something done consistently over time makes long-term changes. So the first step is just moving and moving often. That could be in any way that you enjoy. If you like to walk, if you like to swim, if you like to just get up and change positions throughout the course of the day, do so and do so often. That is a good first start towards changing some movement practices. I like to use the diet analogy. So the first thing is portion control with diet. If you eat less, even if you eat the exact same foods, if your goal is weight loss, that is, you're probably going to lose some weight. Later on, once you get that under control, then you start getting into the specifics of it. So with movement practice, it's about just doing some often. So this would actually be increasing your portion of exercise. Then later on, once you've got that as a part of a habit that your body is in, then you start getting into some of the specifics. And I think any good balanced program should have some aerobic training, some resistance training, and also, as a third feature that a lot of people will forget about, some balance training. So we'll get into a little bit of the details of that. But some of the aerobic training that I think should be a base of a program is anything that involves getting your heart rate elevated and elevated for an extended amount of time. So this is usually advised to be about 30 to 60 minutes, 3 to 4 times a week. So this makes up usually the bulk of a movement practice for general healthy features of a movement practice. Elevated heart rate, about 70 to 80% of max heart rate. If you've got a heart rate monitor, that's easier to calculate. Usually the guideline I give people is breathing to the point where you have a normal conversation that is somewhat labored. So you're having to take an extra breath here and there, but you're also not gasping for air and can't continue talking. We use other tools called rates of perceived exertion, and you're at a moderate rate of perceived exertion with that, with 1 being, oh, I could do this all day, no problem, and 10 being, I feel like I'm going to pass out, this is so hard. So somewhere in the middle there. Resistance training, also really important, and we talked about that for a number of different reasons: bone health, joint health, metabolic health, for muscle mass and muscle health. But 2 to 3 times a week, a general feature that or a general guideline I'll give people is have 1 day upper body, 1 day lower body throughout the course of the week. They're shown to be even good value in those 2 days a week. 1 to 2 movements or exercises for each major muscle. Ideally doing 2 to 3 sets of 10 to 15 repetitions to the point where you're feeling a little bit fatigued. If you feel you can do 20 more reps, you probably need to bump up the weight. If you feel like you're going to fall over after doing 5 reps, you probably need to lower the weight a little bit. But upper body, some pushes, some pulls, and overhead movement generally hits on most of those major muscle groups. Lower body, a squat of some sort, a hinge, which would be some type of a lifting movement, picking something up off of the ground, and then some type of carry where you're holding something and moving, tend to be pretty good when it comes to promoting strength gains and having some resistance training. And by the way, I was just finishing these actually just right before the presentation today. I'll try to get through, Amy, some access to you guys, for you guys to these slides too. So don't feel like you have to get everything right now if you're looking for that. Some type of balance training. We already went into the timing of this a little bit, that 2 to 3 times a week of about 20 minutes, at least for maintenance of balance, tends to be a really good number to shoot for. This sounds like a ton, and it is if you haven't been doing anything. So start small and build as far as what you're working. But in general, once you get into a routine, that ends up being about 30 to 40 minutes, 4 to 6 times throughout the course of the week. So once you get in a routine and you get practice with it, that's oftentimes something a lot of people can carve out if they see that there's real good benefits in it. So it is a lot to ask from going from nothing. But what I want you to take from this is, even if you're doing very little right now, even something is a step in the right direction, and you can build towards doing more. With balance, the key thing with balance, whether it's static, meaning I'm staying in one position, or whether it's moving, I'm moving about my environment and challenging my balance with direction changes and carrying things. Finding a sweet spot is important when it comes to promoting balance changes. If balance is really easy, again, you can do it with your eyes closed, you can think about something else and still stay balanced. It's probably not challenging you enough to the point where you're going to get gain from it. If, on the other hand, you're falling over while you're practicing the very thing you're trying to do to not fall over, it's probably too hard. But a sweet spot of this is challenging but doable and safe. So this little diagram here, just a little bit of a wrap up as I'm finishing things up today. And it's going through something you can ask yourself if you want to. Do you move often? Are you happy with your physical function? If yes, awesome. Keep moving. I'll encourage you there. Hopefully this was just encouragement for you that I'm doing some really good and healthy things. Keep moving, reap the benefits. If you're not, what I would advise is maybe going off of this or something you like to do, start practicing. Or seek out some guidance if you're not sure what to do. If that's not going well as far as the starting practicing, again, seek out some guidance and get to a point where either maybe it's seeking out some physical therapy care, talking to a medical professional, talking with a physical trainer, where you can learn to move well. And as you learn to move well, keep moving well and keep doing it for the remainder of your life and reap the benefits. Still have more questions. We'll go over some questions right now. There's at least a little bit of time, but I always advise talking with your physician. A lot of physical therapist practices, including ours, we offer free consultations too, and that can sometimes be a good way if you're thinking, I don't know, is this really good for me? Do I have, will I get benefit out of this? Free consultations are a great way for a meet and greet with a physical therapist where you can get some of your questions answered. And there are times with those that I say, yeah, this is probably not the best thing for you. You've got to get some other things figured out, and I'm going to try to help you with that too. But for the most part, I'm telling people physical therapy is a good place to start. If you have specific questions for me that don't get answered today, feel free. This is my work email. You can always reach out to me, luke@fullpotentialpt.com. I'm happy to answer questions that you might have. You guys took the time to come here, and I'll give you some time with that also. Any more specific questions for me today? I know that was a ton of information. It was a broad subject that we tried to cover. Sure, yeah.
Let me. Resistance training.
The question was, which is better, increased weight or increased reps when it comes to resistance training? And that is a really good question. In general, the key feature towards promoting strength changes is some level of fatigue being reached by the end. So if it's a relatively low weight and you feel like I'm getting through this and I'm getting through, we'll take a number 10 to 15 reps and it feels easy. You have two options in that case. You can either say, I'm going to do more reps to the point where I get to the point of some fatigue, meaning maybe my technique breaks down a little bit, or I'm feeling like I couldn't get another 5 reps or 5 or 10 reps. That would be a way that you can promote strength, or you can choose to increase the weight and keep the reps the same. So either or, I guess.
So if you have a muscle knotting up after doing a weight, is it better to decrease the weight or decrease the reps?
I would say, again, either would be good places to start, depending on what you want to do. In general, what I'm trying to get people do though, to get you to go one way with that is, in general, my goal is usually to increase the absolute load. With what we see with load and bony changes and with muscle changes, it's hard to replace the absolute load. So typically what I'm trying to do is increase the amount of load that a given muscle group is being put under, which usually means increasing the weight, less often increasing the reps, but either can be an option if, let's say, you don't feel safe with the amount of weight, if you're finding that if you increase the weight, you have a lot more muscle soreness, or if you find that if you increase the weight, you're dealing with really tight muscles afterwards, you can always experiment with the reps a little bit too.
Okay, yeah. Oh, yes, it's you and then I'll.
For some of us who have musculoskeletal issues, one of the things that comes up is a propensity for inflammation. And I didn't see it addressed in any of the slides, but do you have some thoughts on that?
That is a really good point. That inflammation is a part of a lot of painful situations, let's say. So in that diagram with the cup in particular, that cup is overflowing. A big feature that can be put in that cup, I think of it as a pebble, can be inflammation. So if enough pebbles are put in that cup starts to overflow, and inflammation is one of those. What we see over and over again though, is that the right amount of exercise, be it general or if it's joint specific for a given joint, the right amount of exercise and rest combination tends to actually reduce inflammation. Interestingly, we see that with inactivity or just lack of activity at a certain joint, inflammation stays high, or overactivity, inflammation stays high. With the right amount of rest versus work, which is pretty dependent on the person. It's where, again, I think that idea of guidance through some of that movement practice can be important, especially if you have some issues at these joints. What we find is that somewhere in the middle, and it depends a little bit on each person and their comorbidities and whatnot too, somewhere in the middle actually tends to have an anti-inflammatory effect.
I would second that.
All right.
I've found that as I've aged, I have more muscle cramps, like in my ankle, cramping up in the middle of the night. And even if I'm doing yoga poses to fight against it, under the category of muscle and aging is cramping. And what would you have to say about that?
Yeah, I'd say that's another one of those barriers that some people have. Definitely cramping. It's hard to move well when either you cramp during movement or you cramp after movement, or you think it's associated with movement. Cramping is something that there are a lot of potential factors for. So sometimes there can be some diet or specific micronutrients that are involved. We think of electrolytes with that. Sometimes it can be fatigue related, inflammation related. Sometimes it can be neurologically related, in that if a nerve isn't doing quite what it needs to do and giving abnormal impulses to a muscle, that muscle may cramp up. I think in general, some of the best things you can do for cramping though would be making sure you're staying hydrated, making sure you're eating a balanced, healthy diet. So including some fruits and vegetables, getting all your micronutrients, maybe some supplementation with specific electrolytes if it's something that's persistent, and then trying to be generally active as best you can in spite of that. So some stretching routines, some light exercise can be helpful. But I'll be honest with you, there are so many variables that cramping is one of those things that's really difficult. There are certain even pathologies that have a tendency towards cramping, and we don't really know why. At least from my knowledge, things like one of those pathologies would be like diabetic neuropathy. When people have diabetes, especially when they have diabetic neuropathy, they tend to have a lot more cramps. And at least from my knowledge, again, there's not a lot of good information as to why that happens or really even what to do about it. So I don't know if that was a good answer to you or not. Sometimes an answer that says, we don't know exactly why is the best I can give you.
Or just saying it's complicated.
It's
like
complicated.
Other questions?
If you go to an orthopedist, you're really being evaluated for surgery. and they've got one other thing in their toolbox, and that's the shot. Why isn't there more of a multidisciplinary approach? Your opinion?
Yeah. I will
Good
say,
question.
a good orthopedic surgeon, they are also a medical doctor too, so they have a broad area of knowledge, and it goes back to all their medical schooling. But I will agree with you, they are orthopedic surgeons, and orthopedic surgery, they got into it probably for a reason. That's because, well, that's what they really like to do, and that's what they find most gratifying. In general, I'd say orthopedic surgeons, they do a great job, but you're right. They have a hammer, and sometimes they see nails, and sometimes nails are there, and determining appropriateness of surgery can be a really tricky thing, because there are a lot of variables that go into that as well. My best advice, I guess, in some situations where either you're working with an orthopedic specialist or you are considering, do I need something like this, is to try to exhaust some of those more conservative means. And what that usually means is seeking out some different opinions. Now, whether that's from a different orthopedic surgeon, most orthopedic surgeons do not find that to be offensive. They know that someone, if they're going to go through surgery, they know they want them to want to have surgery too. So seeking out some different opinions is a good way to do that, but also working with some complementary groups, whether that be physical therapy, primary care, trying to exhaust some of those more conservative measures. And most orthopedic surgeons, I find, at least in the area, are really good, and they're trying to exhaust some of those before they go to more invasive. Now, there are times where there's really one option and there really is a nail and it really needs to be hit. I think those, there's a whole mix of those cases, but in general, I always like to have people ask, have we exhausted the other conservative options that are available?
I agree with you, Luke. And as a retired physician, I feel like patients should ask for things if they feel like they're not getting it. I tried to be really conscientious, but sometimes people knew what they wanted to try, but they would defer to me. And I think that's especially true with surgeons and orthopedic surgeons. And I think it's perfectly permissible to say, can I try PT first, and will you order that? And I had a hip replacement, and I felt, based on some weakness, that I had residual, and I'm a very active person, so I was quite surprised that I had any weakness, but my glute med got weak. And I didn't even realize it because my activities didn't include that. So I needed a second hip replacement. And I said, first off, I want prehab, and then I want rehab afterwards. And I had a better outcome with this hip. Not that I was really bad at all, but just based on your study, that probably wasn't necessarily indicated, but I just told the orthopedic surgeons what I want.
Yeah.
And so that's what I got. And it helped. And I think that I want to give people as patients permission to advocate for what you need. Because I think, especially in our age group, we always sort of deferred to doctor knows best. And that may or may not have always been true. And I think nowadays we have more modalities too to use, like physical therapy and other alternative modalities of treatment, some of which are covered and some of them aren't, like acupuncture and things like that. So it wouldn't hurt. If my question would be, would it hurt me to try physical therapy? And if they say no, then I would ask for an order for physical therapy.
Yeah. I think that's an excellent question, and thanks
Yeah,
for that
yeah,
opinion too
just
from a
throw that-
retired physician.
Yeah.
It's even more valuable.
Yeah.
Is the cost of your services at full potential covered by the Medicare Advantage programs such as Priority?
It is. So we operate through insurance. Some clinics around town don't, and there's more and more of that happening. It's tough to work with third-party payers sometimes, but we do operate through most major insurances.
Could you talk about feet? I mean, the foot holds all of us.
Yeah.
And there's not very much focus on it, and it affects balance. We're encouraged to buy certain shoes. And I just wonder, are there exercises or any effort to focus on the needs of the foot?
Yeah, we could do a whole new hour-and-a-half long seminar on feet, but when it comes to feet, I see that they're like these other joint areas, which are sometimes, I mean, they're the low hanging fruit. That's what a lot of the systematic reviews, but there's a lot of good research on feet too that just we didn't have room for in this presentation. But it's a complex group of joints, muscles, nerves, tendons, ligaments that are all working together, and they have feet have a lot of important responsibilities. And you mentioned some of them right there. Not only just walking, but they have to have a certain level of strength. They're important for balance. They're sometimes an indicator of otherwise health, like vascular health and whatnot. And I do a lot of work with feet because of all those important needs. And feet can be strengthened. Feet can have arthritic changes. Feet can have some of these other changes, but feet can be strengthened. There can sometimes be some foot sparing steps that can be taken, whether it's shoe wear and whatnot. And I guess what I'm saying is absolutely feet are an area of interest and can be addressed through physical therapy, at least in a conservative sense.
One more question? Do we
One more
have-
question?
Okay.
Yeah.
One more question.
I'm hearing more about laser therapy after surgery. What do you know about that and what's your opinion of it?
I guess even in a broader sense, I'll get to lasers too, but there are a lot of different modalities. And what we say modalities are when it comes to physical therapy are things like laser, ultrasound, electrical stimulation. There are certain types of light therapy that are done like laser, but a little bit different. And I think they all serve their purpose. There's some low-level evidence that things like laser can reduce inflammation and sometimes promote some healing. The mechanisms behind it are not fully understood, at least from what I know. I say low-level evidence, it's not resounding evidence, but in that sense too, they're showing that there are very few negative side effects. So I think what's often seen with like lasers is there is some evidence pointing towards, in some cases, it may be beneficial, and there's very little saying that it actually is a modality that causes any harm, unless it's a high intensity laser that has potential for burning tissue, and they're not going to use that for those post-operative cases. So low level evidence, but very few negative side effects from what we know.
So, well, thank you, Luke, for taking time out of your schedule to come in and talk to us. I think we all learned some new things.
Great. Well, thanks for having me.